Bismillahirrahmanirrahim. The quote of the day is dream as you will live forever and live as you will die today. The topic of today's discussion is polio under the kind supervision of Professor Dr. Saira Afzal. The learning outlines of today's presentation is case presentation, epidemiology triad, clinical features, prevention, diagnosis, differential diagnosis, and treatment of polio. Now, case presentation of a polio. Here is a girl in the diagram which is 4 years old and belongs to a nomadic and low socioeconomic class. She has 8 siblings, have no immunization status, and at the age of 9 months initially presented with fever, malaise, headache, anorexia, abdominal pain, and sore throat, which lasts for 3 days. She recovered from these symptoms and then again developed these symptoms after 4 days, which are no more worse. No, she has also absent deep tendon reflexes and then progresses to floppy weakness of the right lower limb, which is much more pronounced on the proximal part of the limb, which eventually leads to the limb deformity. Now, the introduction to the polio. Poliomyelitis is an acute viral infection caused by an RNA virus. It is primarily an infection of the human alimentary tract, but the virus may infect the central nervous system in a small percentage, only about 1% of cases, resulting in a varying degrees of paralysis and possibly death. Now, the problem statement. In the pre-vaccination era, poliomyelitis was found in all countries of the world. The extensive use of polio vaccines since 1954 eliminated the disease in 12 countries. In 1988, World Health Assembly resolved to eradicate poliomyelitis globally. Since then, implementation of the eradication strategies has reduced the number of polio endemic countries from more than 125 countries in 1988 to only 3 countries in 2014. These 3 countries are Pakistan, Afghanistan, and Nigeria. India has not reported any polio case since 2011 and has been declared polio-free in 2014. Nigeria is the last country to have officially stopped endemic transmission of polio virus with its last 40 case in 2016. On 27th January 2022, Pakistan marked 1 year without a detected case of wild polio virus 1. Though the virus continued to appear in environmental samples from the Khyber Pakhtunkhwa region as recently as the previous month, and polio cases due to circulating vaccine-dried polio virus 2 were seen during the period. 4 of the 6 regions of WHO have been declared polio-free. These are America, Western Pacific, Europe, and Southeast Asia region. Now the polio strains eradicated. Type 2 wild poliovirus was reported, the last case was reported in 1999 and was declared eradicated in 2015. Type 3 wild poliovirus was last reported in November 2012 and was declared eradicated in 2019. In 2016, type 2 oral polio containing vaccine was withdrawn from all routine immunization programs worldwide, replacing TOPV, trivalent OPV, with the bivalent OPV containing only types 1 and 3. So the epidemiological triad of poliomyelitis. The agent is poliovirus. The host is mostly the children below the age of 5 years, and the environmental factors that contribute are overcrowded place, contaminated water, food, and rainy season. Now the agent factors. The causative agent is poliovirus, and there are 3 serotypes known that are wild poliovirus 1, 2, and 3. And outbreaks of paralytic polio occur mostly due to the type 1 virus. And the survival of the poliovirus is that it lives in water for 4 months and in feces for 6 months. The virus is inactivated by the pasteurization and a variety of physical and chemical agents. Reservoir of infection is only the man, and most infections are subclinical. Infectious materials are feces and oropharyngeal secretions of an infected person. Period of communicability. Cases are most infections 7 to 10 days before and after the onset of symptoms. In the feces, the virus is excreted commonly for 2 to 3 weeks and sometimes as long as 3 to 4 months. Now the host factors. Age. It can occur in all age groups, but children are usually more susceptible. More vulnerable age group is between 6 months and 3 years of age. Yeah, male to female ratio is 3:1, and risk factors of paralytic polio in polio infected people is are fatigue, trauma, intramuscular injection, tonsillectomy during epidemic, and alum containing diphtheria, pertussis, and tetanus vaccine. Know the immunity. Maternal antibody gradually disappears during 6 months of life, and immunity after infection is solid, but does not confer immunity for other two types. If infection is caused by one type, then it does not confer immunity for the other two types. Know the environmental factors that contribute to poliomyelitis infection are the rainy season, and in Pakistan it mostly occurs during the season of June to September, and it occurs mostly in overcrowded and poor sanitation areas. Now the mode of transmission. It can spread through droplet infection and fecal-oral route. Through droplet infection, it is rare and occur in only acute phase of the disease, and it occurs in those people who has close personal contact. And fecal-oral route is the main route of spread, and it spreads directly through the contaminated fingers and indirectly through the water, milk, food, and flies. When the virus is excreted in the feces, it comes to the households by the contaminated fingers, poor sanitary hygiene, and then it infects the other children and people. The incubation period is 7 to 14 days, and it can with the range of 3 to 35 days. Clinical manifestations. The most of the cases, like 91 to 96%, are inapparent or the subclinical infection in which there is no disease and there is no sequelae. These are the subclinical cases. While the clinical manifestations in which the disease appears are the abortive poliomyelitis, in which contributes 5% of the cases, non-paralytic poliomyelitis, which contributes only 1%, and paralytic poliomyelitis, whose participation is less than 1%. Now the abortive poliomyelitis. It occurs 1 to 2 weeks after infection, and in it there is influenza-like syndrome occurs. The prominent features are fever, malaise, anorexia, and headache. Other features are sore throat, abdominal or muscular cramps, and irregular vomiting. It lasts for 2 to 3 days, and the recovery is complete. And there are no neurological signs and no sequelae. The diagnosis is made by clinically, and diagnosis cannot be made clinically, and it is made only by the virus isolation and the rising antibody titers. Now the non-paralytic polio. The symptoms are intense headache, nausea, vomiting, soreness and stiffness of posterior muscles of neck, trunk, and limbs, fleeting paralysis of the bladder, and constipation. Signs are signs are the basic signs of diagnosis are knuckle rigidity and spinal rigidity. There is head drop in the patient, and there are no sensory defects. Reflexes. Reflexes are normal initially unless paralysis supervenes. Changing in reflexes, either decreased or increased, may precede weakness by 12 to 24 hours, and the deep tendon reflexes. Spinal and gluteal reflexes may disappear before abdominal cremasteric reflex. Deep tendon reflexes are absent with paralysis and occur 8 to 24 hours after the superficial reflexes are depressed. The non-paralytic polio stage, paralytic polio lasts for 2 to 10 days, and the recovery is rapid. Now the paralytic poliomyelitis. It is again divided into three types, and it is differentiated only by the portion of the CNS most severely affected. It may be spinal paralytic, bulbar, or the polioencephalitis. Now the spinal paralytic poliomyelitis. It has two phases. In first phase, there is the symptoms are almost all those of the abortive paralysis, which are influenza-like syndrome, and then there is recovery for 2 to 5 days in which the patient remains asymptomatic, and then the second phase starts in which the spinal paralytic poliomyelitis occurs. In this, there is the severe exacerbation of the previous symptoms, and the distribution of paralysis is maybe is spotty. It can involve single muscle or group of muscles and diverse patterns. It Within 1 to 3 days, asymmetric paralysis, flaccid paralysis or paralysis occur, and its most common involvement is leg and then one arm. Proximal areas are more commonly affected than the distal ones in extremities, and little recovery is noted for paralysis and continue for 18 months. If no recovery appears within a month, then permanent paralysis develops. And then there is the atrophy of limb, failure of growth, and deformity in the growing children. Now the bulbar polio. The nuclei of the cranial nerves are involved, causing weakness of the split muscles and maybe encephalitis. Bulbar manifestations include dysphagia, nasal voice, fluid regurgitation from the nose, difficulty in chewing, facial weakness, and diplopia. Paralysis of the muscles of the respiration is the most serious life-threatening manifestation, and that may occur due to respiratory muscle paralysis. Now the polioencephalitis. In it, higher brain centers are involved, and serious coma and spastic paralysis may occur. Irritability, disorientation, drowsiness, and coarse tremors are often present with peripheral or cranial nerve paralysis that coexist or ensures. Hypoxia and hypercapnia due to respiratory insufficiency may produce disorientation without true encephalitis. Now the diagnosis of poliomyelitis. Paralytic polio may be suspected in individuals experiencing acute onset of flaccid paralysis in one or more limbs with decreased or absent tendon reflexes in affected limbs and without sensory or cognitive loss. WHO recommends that a laboratory diagnosis of polio should be confirmed by isolation and then identification of the polio in stool samples with specific identification of type, of wild type and vaccine associated polio. In suspected cases, two stool samples are collected 20 to 24 hours apart as soon as possible after the diagnosis of polio is suspected. In laboratories that can isolate the poliovirus, the isolates should be sent to US Center for Disease Control and Prevention or one of the WHO certified laboratories where DNA sequence analysis can be performed to distinguish between the wild type of the virus and neurovirulent or revertant OPV strains. Now the differential diagnosis. Differential diagnosis of polio is made by the by the diseases that have acute flaccid paralysis. Acute flaccid paralysis is defined as sudden onset of paralysis or weakness in any part of the body of a child less than 15 years of age. The major clinical causes of acute flaccid paralysis are Guillain-Barré syndrome, CNS infections, CNS tumors, transverse myelitis, myasthenia gravis, hypokalemic paralysis, botulinum, and West Nile virus. Now the treatment. There is no specific treatment for poliomyelitis. The only treatment that can be given is good nursing care from the beginning of illness that can minimize or even prevent crippling. Physiotherapy is of vital importance. It can be initiated in the affected limb immediately and it helps the weakened muscle to regain strength. Now the prevention. Immunization is the sole effective means of preventing poliomyelitis. Both killed and live attenuated vaccines are available and both are safe and effective. Two types of vaccines are used throughout the world that are inactivated polio vaccine that is called the IPV and oral polio vaccine that is called the OPV. First of all, we discuss the inactivated polio vaccine IPV that is also called the SAL. It is made from the selected wild polio virus strains that are from the strains of type 1, 2 and 3. The final vaccine mixture is formulated to contain at least 40 units of type 1, 8 units of type 2 and 32 units of type 3 antigen. It is administered intramuscular injection or that is preferable, or it can also be administered subcutaneously. The primary initial course of immunization consists of 4 inoculations. First 3 doses are given at the intervals of 1 to 2 months. Fourth dose is given 6 to 12 months after the third dose. First dose is usually given when the infant is 6 weeks old. Additional doses are recommended prior to school entry and then every 5 years until the age of 18. Alternatively, 1 or 2 doses of live vaccine, oral polio vaccine can be given safely as boosters after an initial course of immunization with inactivated vaccine. Advantages of IPV. Because it does not contain living virus, it is safe to administer to persons with immunodeficiency diseases, to person undergoing having a corticosteroid or radiation therapy, or to those over 50 years or who are receiving vaccine for the first time and during pregnancy. The drawbacks are IPV includes humoral antibodies, IgM, IgG, and IgA serum antibodies, but does not induce intestinal or local immunity. The circulating antibodies project that individual against paralytic polio, but do not prevent reinfection of the gut by the wild virus. For the individual, it gives protection for paralysis, but and it does not do anything more. For the community, it offers nothing because the wild viruses can still multiply in the gut and the course of infection to others. This is a major drawback of the IPV. Further, in the case of an epidemic, IPV is unsuitable because immunity is not rapidly achieved as more than one dose is required to induce immunity. Injections are to be avoided during epidemic times as they are likely to precipitate paralysis. Therefore, IPV is not efficacious in combating epidemics of polio. Know the oral polio vaccine, that is also called the SABIN. The WHO program on immunization and national immunization program in Pakistan recommend a primary course of 3 doses of oral polio vaccine at 1 month interval, commencing the first dose when the infant is 6 weeks old. It is recommended that a dose of oral polio vaccine, that is 0 dose, is required to be given to all children delivered in health institutions before their discharge from the hospital. The vaccine should be given in maternity wards. The newborn should not be taken to regular immunization sessions to avoid infection. It is very important to complete vaccination of all infants before 6 months of age. This is because most polio cases occur between the ages of 6 months and 3 years. One booster dose of OPV is recommended 12 to 18 months after a month later. Know the development of immunity. Following the administration of the OPV, of IPV, live vaccine strains infect intestinal epithelial cells. After replication, the virus is transported to the pair patches where a secondary multiplication with subsequent viremia occurs. The viremia spreads to other areas of the body, resulting in the production of circulating antibodies which prevent dissemination of virus to the nervous system and prevent paralytic polio. Intestinal infection stimulates the production of IgA secretory antibodies, which prevents subsequent infection of the alimentary tract with wild strains of poliovirus, and thus it is effective in limiting virus transmission in the community. Thus, OPV induces both local and systemic immunity. Now, the herd immunity in polio. The vaccine progeny that is excreted in the feces and secondary spread occurs to household contacts and susceptible contacts in the community. Non-immunized persons may therefore be immunized. Thus, widespread herd immunity results, even if only approximately 66% of the immunity is immunized. This property of OPV has been exploited in controlling epidemics of polio by administering the vaccine simultaneously in a short period of all susceptibles in the community. This procedure virtually eliminates the wild polio strains in the community and replaces them by the attenuated strains. The duration of immunity produced by the OPV is not known. It may possibly even be lifelong. Know the advantages of OPV. Since it is given orally, it is easy to administer and does not require any highly trained person. It induces both humoral and intestinal immunity. Antibody is quickly produced in a large proportion of vaccine, and even a single dose elicits substantial immunity. The vaccine excretes the virus and so infects others who are also immunized thereby. It is useful in controlling epidemics and it is relatively inexpensive. So the complications of OPV. Being live viruses, the vaccine viruses, particularly type 3, do mutate in the course of their multiplication in the vaccinated children, and rare cases of vaccine associated paralytic polio have occurred in the recipients of the vaccine and their contents. This is the main drawback of the OPV. Know the contraindications. It is recommended that diarrhea should not be considered as a contraindicated to OPV. However, to ensure full protection, a dose of OPV given to a child with diarrhea should not be counted as a part of the series of the child, and the child should receive another dose at the first available opportunity. Live vaccines are not usually given to the immunosuppressed individuals. OPV should be delayed until after pregnancy unless immediate protection is required when IPV is indicated. This is the routine immunization schedule of Pakistan in which OPV is given as a zero dose soon after birth, and OPV 1, 2, and 3 is given at the age of 6, 10, and 14 weeks, and IPV is given at the age of 14 weeks, and then recently it is added in the 9 months of age. Now the polio surveillance or the AFP surveillance. The polio surveillance is very important for the monitoring and the surveillance of the polio. The first step in surveillance is finding and reporting children with AFP. In this, all the children that are coming in tertiary care hospitals or the district headquarter hospitals or any health facility with the suspected AFP cases are evaluated for polio, and the public health personals may also go to the hospitals to evaluate the AFP cases. The second step in this is the transporting stool sample for analysis. The suspected AFP cases are the stool samples are sent to the uh, laboratory for the diagnosis, and then the third step is isolating the polio viruses for the isolation and then identification of the wild polio virus or the uh, vaccine derived poliovirus, and then the last step in surveillance is the mapping the virus. In this, the virus genomic sequence is compared with the already available sequences so that the exact geographic location of the virus can be identified. Now the environmental surveillance. It involves testing sewage or the other environmental samples for the presence of poliovirus. Environmental surveillance often confirms wild poliovirus infections in the absence of cases of paralysis. All stool specimens collected from reported AFP cases are tested at the regional reference laboratory for polio eradication in Islamabad. Testing stool surveys for healthy children. Polio eradication criteria. Certification of the polio eradication. It is conducted on a regional basis. Each region can consider certification only when all countries in the area demonstrate the absence of wild polio virus transmission for at least 3 consecutive years in the presence of certification standard surveillance. In non-epidemic countries, even a single case is considered an epidemic. In Pakistan, regarding the polio, Pakistan Polio Eradication Program is in progress. The partners and donors for this program is the government of Pakistan and the uh, partners such as WHO, UNICEF, Bill Gates and Bill and Melinda Gates Foundation, Rotary International, and the Community Disease for Center for Disease Control. Now, this is the data for the wild polio vaccine polio cases across Pakistan in all the provinces of Pakistan since 2015. In 2015, there are 54 cases. In 2016, 20 cases. 2017, 8 cases. In 2018, 12 cases, and in 2021, only one case of wild polio virus has been reported. Now, this is the data for the circulatory vaccine dried polio virus 2 cases across the Pakistan provinces. In last year, only 8 cases are reported. Now, this is the map of Pakistan showing uh, uh, the different tiers for the polio vaccine. The different tiers are the core reservoir districts that are shown with the orange color, and high risk districts which are shown in pink color, and vulnerable districts that are shown in light green color, and low risk districts that are in green color. Since 1988, after the global polio eradication initiative, only two countries are left in which polio is still endemic, and these are the Pakistan and Afghanistan. And this is a progress towards polio eradication in 2020. Now, these are in blue. These are the regions which are WHO certified polio free, while in the red these are the endemic countries that are Pakistan and Afghanistan, and in yellow these are the polio free but not certified by the WHO. Now these are the estimated cases of polio by world region from 1980 to 2020. In 1980, the estimated polio cases are more than 4 lakh, and uh, in 2016 only less than 100 cases are left behind. And this is all the reported polio cases in 2022. The wild polio virus, only one case is reported in 2022 to till date, and the circulating vaccine trial polio cases, 20 cases has been reported. As of 29 March in 2022, one case of wild polio virus polio had been reported in Afghanistan. Now the time for the MCQs. First MCQ is India is declared polio free in 2014 by eradicating the transmission of polio. Polio can be eradicated by which of the following means: by merely need attention to the sewage control and hygiene, or by inactivity polio vaccine only, or live polio vaccine only, or by the combination of live and inactivated polio vaccine.
D.
Yes, D is the correct answer. Polio is one of the dreaded disease that left its victim paralyzed and disabled for life. More than 90% of the people who become infected with polio virus experience whether remain symptom-free, have influenza-like syndrome, or transient floppy weakness of limbs, or paralysis of one or more limbs.
A.
Yes, A is the correct symptom, as more than 90% of the polio-infected patients remain symptom-free. On 27 January 2022, Pakistan marked 1 year without a detected case of wild polio virus 1 caused polio, by which criteria any region can be declared and have certification of polio eradication, whether no positive environmental sample for polio virus for at least 1 year, or the number of polio confirmed cases no more than one for 1 year, or after the achievement of herd immunity, or by the absence of wild polio virus cases for at least 3 consecutive years in the presence of standard surveillance system.
D.
Yes, D is the correct option. Fourth MCQ is, you are working as a public health manager in a country XYZ where polio is declared polio free for the last 12 years. 3 laboratory confirmed cases of polio has been reported probably due to large number of immigrants from polio endemic country. Which measure you will take to stop its spread? Whether by mass level vaccination with OPV, or by the mass level vaccination with IPV, or immunization with the human normal immunoglobulins, or advice regarding personal hygiene.
A.
A.
Yes, A is the correct answer. The hint in it is if the epidemic occurs, the vaccine that is of use is OPV. Fifth MCQ is polio is a contagious disease, but its spread can be controlled by immunization as listed after the launch of the Global Polio Eradication Initiative in 1988. Choose the correct for the herd immunity regarding polio. Option A is by merely vaccinating 50% of population, or vaccine progeny is secreted in the feces and secondary spread occurs to susceptible contacts in community which then become immunized, or all the individuals in the community has to be vaccinated, or it cannot be achieved.
B.
Yes, B is the correct option regarding herd immunity in polio. Sixth MCQ is polio vaccines are generally safe, but rarely vaccine associated paralytic polio can occur following vaccination, which are clinically indistinguishable from the wild polio virus, but can be confirmed by laboratory. It is caused by whether inactivated polio vaccine, oral polio vaccine, mutations in wild polio virus, or can be caused by any vaccine.
B.
Yes,
OPV.
OPV. As the in OPV the virus is live, so it can cause vaccine associated paralytic polio. Seventh MCQ is a child 4 years of age with poor socioeconomic class and incomplete immunization status has paralysis of his right lower limb with negative Babinski sign, exaggerated deep tendon reflexes, and sensory loss over the affected area. With which disease is he suffering from? Whether it is poliomyelitis, some other disease, hypokalemia, or nutritional deficiency.
Alpha, poliomyelitis.
Ninth in this MCQ is sensory loss. In polio, there is no sensory loss of the patient. So the correct option will be some other disease. Eighth MCQ is you are working as a family physician in a town XYZ and a child of 2 years come to you with floppy weakness of his right arm for 2 days. What step will you adopt further for diagnosing poliomyelitis infection? Whether to collect 2 samples of stools 24 hours apart and maintain a reverse cold chain and send it to laboratory, collect 3 cc of patient's blood for virus isolation. As part of AFP surveillance, it is considered as a confirmed case of polio or to perform a physical examination to confirm the diagnosis.
A.
Yes, A is the correct option. Ninth MCQ is a child of 4 years of age who is currently on corticosteroid therapy for severe asthma needs to have polio vaccine. What you will recommend her regarding polio vaccination? Whether you will recommend OPV, IPV, or both OPV and IPV are contraindicated in this patient. And none of the polio vaccine is recommended for this age group.
B.
Yes, B. Inactivated polio vaccine should be recommended. 10th MCQ is a mother took her 5 years old girl for her treatment who presented few days ago with limb weakness and then laboratory diagnosis of poliomyelitis inconfirmed. Know how you will treat her. Whether with antiviral drugs will be prescribed for 3 months, only supported treatment and counseling, or surgery to relieve nerve compression, or give both OPV and IPV.
B.
Yes, B is the correct option as no treatment is available till date. Thank you very much for today's presentation.
Dr. Awais, kindly unmute the ma'am.
मेरी तरफ से अनम्यूट है लेकिन देखो